Good morning, everybody. At the outset, I would like to thank Dr. Love for this opportunity, and I am going to share my experience, rather our experience in the center where I work. It's a purely rural center, so you can get a little bit of rustic flavor in my presentation. And if you look at the incidence of pediatric traumatic cataract, Western literature reports about 30%, but according to our experience, it is 40 to 45% because the rural children are mostly exposed to some dangerous games and all those. They are more exposed to trauma compared to the urban children. These are the different etiology already discussed, but what I would like to say, two unique things, that in our place we get some religious events where the sweets, like the candies, these are thrown among the devotees, and children try to catch it and hit those sweets hit the eye and they develop cataract. It's very common at our place. And another one is the bird beak injury and hypodermic needle injury, because nowadays the people are aware about using disposable syringes, but they are not careful about the disposal in a proper way. They just throw it here and there, and it becomes a toy for the children, and we get a lot of injuries by this hypodermic needle, used needle one. And the bird beak injury is also common among the farmers' family. So these are some of the pictures, and really it's a very challenging thing. Already it has been discussed that first thing is very difficult to examine the child as a whole because of the age, and surgery is again very challenging. Inflammation is much more because of the nature of injury, and usually because of the age and infection, they multiply the inflammation, and associated injuries also in the other parts of the eyes. That is also managing that thing also is a challenge. It's a multitask, and surgical skill of the person who is managing it, that also is an important issue. And see some of the children neglected for a long time, and the eye has already gone exotropic. And if we look at the surgical challenges, maybe multiplied by other structural injuries, more chance of inflammation and more chance of optic capture and early PCO formation in these cases. And sometimes you may have lot of difficulty in IOL power calculation in presence of corneal irregularity, and you may have to do the biometry using the keratometric reading of the other eye, and in the back placement of IOL may not be always possible in this case. And sometimes in neglected cases the capsules become very much fibrous. The anterior capsule, posterior capsule, they are stuck together in neglected cases, and poor dilatation of the pupil because of the synechia already formed due to inflammation. All these really pose a challenge for the surgeon, and is an example of extremely thick PC. I remember I had to cut this with scissors. With vitrectomy I could not manage this PC. I had to use the scissors, Vanna's scissor, to manage this PC. And the initial management is important. Initial treatment with antibiotic and atropine and steroid. If we see that the infection is not that much, we can use steroid initially. And examination is very important. It should be in as much detail as possible, and this is a must. Ultrasound B scan, already Dr. Sumita has mentioned this thing. And explaining prognosis is an important part, because the parents should know what is the outcome and the possibility of additional surgeries after removal of cataract, then amblyopia therapy, and all those things need to be explained beforehand, before taking up the case for surgery. And planning surgery is also an important issue, and what we face in our day-to-day practice in the rural area is not a planned surgery. Most of the cases are emergency one. The children come with systemic infection, mostly respiratory tract infection, and anesthetist is always not ready to give anesthesia to that child. So this is an example of the case where we did primary repair of cornea and loose cortex aspiration, ECC, as a primary procedure, and then we put the secondary IOL in this case because we had a doubt that there may be some amount of infection and we did not put the IOL, and we had a doubt that the child may need some posterior segment intervention. And the two sittings we did surgery in this. Sometimes you have to do like that. And like this child had undergone cataract surgery, and after removal of cataract some retinal break was found, and you can see the cryo mark here. It's an old picture. So if you look at the outcome, we see that the broomstick and hypodermic needle injury, these are the worst prognosis because of the infection, and other surgeries 40% showed fair to good outcome. But again, another limitation is a very bad follow-up. And I'm going to share some of the pictures. Somehow IOL is inserted. You don't have much choice to fashion the surgery. And see, at least an IOL is there. And this is all the inflammatory deposits over the IOL. These are all PMMA IOLs. And it's optic capture causing lot of problem. And these are some desirable outcome like good posterior capsular opening and well-centered IOL. So the key for any cataract surgery in child is placing the IOL in a capsular bag with an opening smaller than the optic. That is the most assured way of preventing pupillary capture, and that can ensure a good visual rehabilitation for the rest of the life. And we are left with very little surgical option because you don't know what is the condition of the capsule is. So it is one of my personal experience. For last 4 years I have tried it. I tried to fashion capsulotomy in such a way that capsulorhexis is performed carefully, avoiding the ruptured part of the anterior capsule, leaving behind a strip of capsule resembling a seat belt. And I named it seat belt capsulotomy. I am just going to share some of it. Like this is the seat belt that is preventing the lens to come forward, like the seat belt in the car. And this is so this is the usual staining, and we are going to perform a capsulotomy here. This has to be done with gentle care because we have to preserve this part, because this is the original site of injury, and the child has reported late, so already this part has become fibrosed. So we are using this intact part for capsulotomy. It needs a lot of care, otherwise you rupture this part. So this is the capsulotomy, anterior capsulorhexis, and this is the injured part. So now we are making the posterior capsulotomy, posterior capsulorhexis. So I'll just show you the outcome. Suppose this is the ruptured lens, and capsulorhexis is performed here, and this is working as a seat belt. So the lens is put here, and this is preventing the lens to come out. This is the immediate postoperative, maybe after one to 2 weeks or so, and the child is maintaining, and we have done follow-up of good number of cases, and the lens is really maintaining good centration. So this is a good experience, but this may not be possible in all the cases. Otherwise you have to go for posterior capsulorhexis, and put the IOL in the sulcus and make an optic capture inside the capsule. If you don't have the posterior capsular support, then you are only left with the option of putting the lens in the sulcus, and if the patient can afford, the multi-piece hydrophobic IOL is the best choice. So here are some of the examples in the follow-up. This is one seat belt, this is one seat belt, this is one seat belt, and this is one. This one we had to cut with the ear glazer after 6 months. So this is an option, just my experience I wanted to share with you. Thank you very much.
Thank you, Dr. C.